Hello and welcome back to this Langford Academy episode. We're talking about laryngeal paralysis today, and this is part 2 of the series where we're going to talk about surgery, both the timing of the procedure and what procedure to perform. My name's Meakin, I'm Head of Soft Tissue Surgery here at Langford Vets, and this video is done as part of the Langford Academy YouTube channel. Please do like and subscribe to our channel because it really does help with our ratings and will help with our numbers going forward. So the summary so far with this case is a dog called Duke. We're suspicious that he's got idiopathic laryngeal paralysis and polyneuropathy, and the questions that we were thinking about is whether he requires surgery, and if he does require surgery, what procedure should we perform? So in terms of whether surgery is required or not, the vast majority of the dogs presenting with laryngeal paralysis are often older, and so what we have to balance is the risk of the anaesthetic and the risk of the procedure itself with the quantity and quality of life that these dogs have got remaining. Often, as is the case with Duke, they've got concurrent polyneuropathy, which is causing the laryngeal paralysis but also causing deficits in the limbs, and that can progress to ataxia and the dog's going completely off their legs. And because it's a degenerative condition, there's no cure for it, there's nothing we can do to fix these animals. So again, we have to really balance how are these animals going to do in the long term. If we go ahead and do surgery for laryngeal paralysis, is that actually going to extend this dog's quality of life? Because what we often find is that we don't operate immediately, and then the proprioceptive deficits can progress before the laryngeal paralysis progresses. So generally we try and treat these animals conservatively if we can, which will come on to how we do that, and then really just monitor them going forward. But we need to know that the laryngeal paralysis itself is affecting the quality of life. The animals aren't able to go for a walk, they're collapsing, they're not able to run and so on. So we'll usually go for a period of conservative management if we can. So as long as these dogs are able to be discharged from the hospital, then these sorts of things will be able to help the animals in the short term. And as I say, if things do progress, we would reconsider surgery at that point. So the animals need to be nice and slim because any extra weight that they're carrying will be not only causing it more difficult for them to exercise, but also be weight around the larynx. So fat deposits will be in the neck around the larynx, and they'll be pushing on the larynx itself, which will make it harder for the dog to abduct the laryngeal cartilages during inspiration. We want to avoid any neck leads, and nothing around the neck, no collars, no slip leads, nothing like that. If you do need to walk them, we'd recommend doing it on a harness or on some sort of halter where it's going around the muzzle, but nothing around the neck, again, that could put extra pressure on the larynx. We try and modify the exercise, so we don't want these dogs to be exercising really vigorously. Some dogs won't cope with off the lead exercise, but they're quite happy exercising on the lead. And so if that's the case, that would be the preference rather than having to resort to surgery. Avoid overheating, so we're trying not to walk these dogs on the sort of hot summer days in the middle of the day. Try and walk them early morning or last thing at night when it's a little bit cooler. And if it's a really hot day, then potentially just avoid walking them on those days at all. Make sure there's a nice cool area of the house that they can lie down in, again where they're not overheating, and you can have fans and air conditioning and things like that to help if you've got that available. We want to try and avoid stressful situations because again that can cause this vicious cycle where they start to have breathing difficulties, that causes inflammation of the larynx and things just start to escalate. And alongside that, we can give anxiolytic medication at home, so things like trazodone, which can just help to calm the animals down, again meaning that we don't have to operate as soon because they're a bit calmer at home and not getting as stressed. And then these animals, we've already said, are prone to aspiration events, and so if they do need to have antibiotics for aspiration pneumonia, that's also something that you can do to help with the breathing. And you may find that they do aspirate intermittently, and they do just need antibiotics every so often just to help get on top of that. So all of those things can help to delay the inevitable, and sometimes, as I say, those animals won't actually need surgery because we've actually managed them really well, and other things have kind of caused an issue beforehand and the owners don't then want surgery. But it also might be that the laryngeal paralysis is affecting the quality of life. The dogs are really struggling to breathe, they're not able to do even short bursts of exercise, and that they might be ones that are repeatedly obstructing like Duke has done, which again we need to resort to surgery because that animal could have a life-threatening obstruction if we don't. So if we do decide to go to surgery, the most common procedure that's performed is a left-sided unilateral laryngeal tieback. And essentially it's the CAD muscle, the cricoretinoideus dorsalis. It's that muscle that's become paralysed, because that's kind of the muscle that will abduct the larynx during inspiration. And we're trying to recreate the function of that muscle by putting in non-absorbable sutures in roughly the same place that the muscle runs. So these sutures are going to hold the larynx permanently open, but what we know from more recent work by Eric Monet and others is that we don't want the larynx too open, because if we pull it open too much, those animals are going to be much more likely to aspirate going forward. So we have these animals intubated during surgery, and what we actually find is that if we tie the larynx open at the level it's held open during the ET tube, that's about the right level. So having an ET tube in the larynx during surgery means the larynx is abducted appropriately, and we probably just want to put sutures in to stabilise it at that point, rather than really disrupt the articular joint within the larynx and try and really hoik it open more than that. It's a bit different if the dogs have got laryngeal collapse, if we're doing a tie back for that, but for laryngeal paralysis, where the larynx is normal, it's just paralysed, we don't want to over abduct that arytenoid cartilage. So at the same time, we usually like to confirm that these dogs definitely do have laryngeal paralysis, so we're going to do that laryngeal exam that we talked about in the last video. We want these animals on a really light plane of anaesthesia, so use whatever drugs you would normally use to induce anaesthesia, whether it's propofol or alfaxan or something else. And we just want to give a really small amount. So we need these animals to be nice and still, but we still want them to have voluntary jaw movement. If they're too deep and they've not got that jaw movement, then the larynx could appear paralysed just because the muscles are paralysed secondary to the anaesthetic drugs, rather than because they've actually got laryngeal paralysis. When you're doing your laryngeal exam, you want the animal to be breathing spontaneously, so sometimes you need to wait a little bit for that to happen again. And when they are breathing spontaneously, you want someone to call inspiration, expiration. So you're going to be looking down the larynx, you're not going to be able to see the animal breathing. So you want to know when the animal's inspiring and when it's expiring. And what should happen is the larynx abducts on inspiration, and then it should relax down on expiration. Sometimes with these animals, when they're paralysed, they'll have what's called paradoxical movement. And what we mean by that is when they forcibly expire, that's going to blow the laryngeal cartilages open, and it will look like they're abducting, but actually that's on expiration, not inspiration. So what you're looking for is a nice coordinated laryngeal abduction on inspiration, and if that's happening, then you know that animal doesn't have laryngeal paralysis. If that's not happening, you then need to consider, well, is the animal too deep? Is there another cause that it's not able to move its laryngeal cartilages? And if not, then probably the animal does have laryngeal paralysis. But we've certainly had animals referred in to us, which the referring vet has thought was paralysed, and actually, when we look at the larynx here, it's functioning normally. So when you're doing this, make sure you've got all the kit available that you need. So we typically would have 2 laryngoscopes with really nice long blades, because you need one to depress right down at the back of the tongue to pull the epiglottis down, and the other one to lift up the soft palate to have a proper unobstructed view of the larynx. You can use a tongue depressor or something else. Make sure your ET tubes are there ready in case the animal obstructs and becomes cyanotic. And make sure you've got enough induction agent that you can rapidly induce anaesthesia if you need to, so that you can intubate the dog. We'd also like to try and pre-oxygenate these dogs, so we typically would give them flow by oxygen for 3 to 5 minutes before induction of anaesthesia, because that will just give you a slightly longer window that if you are spending a bit of time looking at the larynx and the dog's not breathing during that time, that you're safe to do that, and then the animal's not going to become hypoxic. And obviously, if possible, we try and measure the SpO2, so have a pulse ox on the animal, either on the tongue or somewhere peripherally like a foot or an ear, just to make sure that the animal's not becoming hypoxic, if they'll tolerate that. So if we have confirmed laryngeal paralysis and the animal is a candidate for surgery, then we'd normally go ahead and do a tie-back procedure. So this is quite a challenging surgery if you're not familiar with it, because it's an area that people don't often operate on. It's a lateral approach to the neck, and you need to make sure that you do the surgery really well, because what you don't want to do is have your sutures fail or tear the laryngeal cartilages, and then have to try and do a salvage surgery, because it's always better to do the surgery correctly first time round. So what I'd say is, if the animal can afford referral, the owners can afford referral, it might be one that you would consider sending to a specialist if you're not used to doing these procedures, because they are technically a bit more challenging, and as I say, something that most vets won't be familiar with in practice. But if you have done these before and you're comfortable doing the surgery, then hopefully I've got a few tips that will help you. So this animal's a nice thin dog, so the landmarks are nice and easy to see on the slides here. So the first thing we're doing is we're looking for the jugular bifurcation, which you can see quite clearly on the image here. So you've got the jugular running up the neck from the right hand side of the screen, and then bifurcating roughly in the middle of that patch that's draped out. Once you've found that, you then want to do an incision just underneath the jugular vein, a longitudinal incision parallel to the jugular just underneath it. And you want that incision probably to be about 3 to 5 centimetres in length. You might need to do it longer to start with if you're not familiar with the anatomy, just to make sure you can see what you're doing properly. But if you know what you're doing, then usually 3 to 5 centimetres would be sufficient. At this point, you want to lift the jugular up with something like a Langford Vet retractor, and then hopefully you'll then start to see the wing of the thyroid cartilage come into view. So you can see in this image here, I've got the adsum forceps behind the thyroid cartilage, so you can feel the wing of the thyroid, and that's got the thyropharyngeus muscle covering it. And so this is the first landmark that you need to identify, and then we're going to make an incision in the thyropharyngeus muscle, and then put a stay suture in the thyroid cartilage, which you can see here, to pull it down during the rest of the surgery. It's really helpful to have multiple pairs of Gelpies for this, because again, that will really help you to see what you're doing. Once you've pulled the thyroid cartilage down, you then there's like a fascial plane that you'll need to go through to see the remaining of the larynx. And then hopefully you'll be able to identify this cricoretinoides dorsalis muscle, so the CAD muscle, which will be going roughly in a 45-degree angle, so from a dorso-caudal direction to a cranioventral direction. And you can see on the image here, I've got a pair of artery forceps underneath the CAD muscle. So you identify the CAD muscle, dissect underneath it, and then you should be able to palpate the muscular process of the arytenoid cartilage, and that's where the CAD muscle will insert. So at this point, I like to then place a straight pair of artery forceps on the CAD muscle, and that will act a bit like a handle, and then we're going to transect the CAD muscle just caudal to the forceps, because we'll need to cut through that to be able to place the sutures. So for me, I'd normally do a cricoretinoid suture. So we then need to pass our suture around the back of the cricoid cartilage, come out just behind the muscular process of the arytenoid, and then pass the suture through the arytenoid cartilage just in front of the muscular process. And that's going to be just a simple proline suture. So for a Labradoodle, I'd usually something like a 2/0 or a 0 proline. You need a nice long needle to be able to get around the back of the cricoid cartilage. If that's gone well, then ideally I'd like to place a second suture in roughly the same orientation, but you've got to be a little bit careful, because sometimes these cartilages can be quite brittle and they can snap, and if they do snap, then your sutures might not hold very well. So that's the reason why I try and get all the way around the back of the cricoid to come out just caudal to the muscular process, and also why I then pass my suture just slightly rostral to the muscular process, because often you'll find the arytenoid is a bit more solid at that point. It'll be a little bit easier to place those sutures reliably. If there are issues and the sutures don't hold or they're tearing through, then often I would then change what I'm doing and do a thyroarytenoid suture, because for that one you're placing both sutures from the back of the arytenoid through the thyroid cartilage, and I find that grips the arytenoid a little bit better, but hopefully you won't find you're in that position. If that's all gone well, whichever suture I feel is the most secure, I'll then tie that one first of all. And then I quite like to extubate the dogs at this point. That's for two reasons. Firstly, to check you've not sutured the ET tube in place, but also to check you've got roughly a good degree of abduction. So say not too much abduction, but you want to see a clear asymmetry for the larynx. So this is Duke after his tie backs. Hopefully you can see that on the right of the image, which is the dog's left, that laryngeal, that arytenoid cartilage is kind of tucked back out of the way. So hopefully these red lines make it a little bit more obvious. So you can see on the right there, the arytenoid is on the midline, and on the left, hopefully that red line makes it a bit more obvious. We've got a nice degree of abduction on that arytenoid. So So we want to make sure that the epiglottis will still cover the larynx, so we don't want it to be over abducted, and as I say, for this one I think that's about right. At this stage I'll then tie my second suture, and that's really a bit of an insurance policy, that if the first one breaks, then I've got my second suture there to hold things open. If I feel like I could abduct it slightly more, so if I look down the larynx and feel actually I'd rather have it a little bit more abducted, then I'll tie the second suture slightly tighter, just to pull it a little bit more open. But if I'm happy with the degree of abduction with the first suture, then I'll try and do the second suture at roughly the same amount of tension. Once all that's gone well, I'll then go back to the surgical site, do a really careful repair of that thyropharyngeus muscle, because that's quite an important muscle for swallowing, and we want these dogs to be able to swallow properly as soon as they're awake, so try and oppose that muscle quite carefully. We'll then usually do a splash block of bupivacaine just to allow some post-operative analgesia, and hopefully that will mean we don't need as much opioid post-operatively, which I'll come on to in the next video. Then finally we're going to close the platysma muscle, and then I quite like doing intradermal skin sutures, these with a bit of glue if needed, just to make sure things aren't rubbing on the neck. So hopefully you'll find that video quite a useful practical guide about when and how to do a laryngeal tieback. If you did find it useful, then please do join us for part 3, where we'll talk about the post-operative management and also the long-term changes the owner needs to make for a dog with a tieback.